Hi everyone, I am Dr. Sharda. I work as Assistant Professor in Indira Gandhi Institute of Child Health in Anaesthesia Department. My title of presentation today is An Unexpected Googly in a Post-Tracheal Dilated Subglottic Stenosis Infant, a Case of Bottleneck Effect. This case particularly challenged us with specific airway concerns and tested our team coordination. So I'll briefly walk you through the case capsule, anesthesia management, particularly focusing on airway management. This is the brief case capsule. A 3-month female baby weighing 4.5 kgs presented with complaints of noisy, hurried breathing, cough after breastfeeding, brassy voice while crying since 3 days. Symptoms improved when the baby was held 45 degrees upright or while asleep. There is no history of cyanosis and there is no known comorbidities. The baby was breastfed and now on diet tube feeds. Birth history, it was a term gestation. Emergency C-section was done for meconium aspiration syndrome. Birth weight was 4 kg. History of 15 days of mechanical ventilation in view of respiratory distress was present. Postnatal course, there was history of stridor after 20 days of extubation following mechanical ventilation after birth. This was associated with history of cough while feeding. Rigid laryngotracheobronchoscopy and dilatation for grade 1 subglottic stenosis at 1 month of age was done. Following this dilatation, the baby was intubated with 3.5 cuffed endotracheal tube and was ventilated for 48 hours electively as per protocol. The baby was on IV dexamethasone nebulization with salbutamol, budesonide, and on clinical examination, the baby had poor nutrition, failure to thrive, and there were no obvious deformed faces. Heart rate was 160 beats per minute and respiratory rate was 40 to 50 cycles per minute. Saturation at room air was 95%. However, on respiratory system examination, suprasternal and subcostal retractions were present. Bilateral normal vesicular breath sounds were present. Cardiac and nervous system examination was. So as we see here, the hemogram of the patient was normal and coagulation profile was normal. So the summary of the case is, this is a 3-month-old female baby with failure to thrive, with post-intubation sequelae, with recurrent subglottic stenosis after dilatation. So what is the googly? What are the challenges we faced in this case? So what was the plan of anesthesia we had considered for this patient? What we actually planned was to provide monitored anesthesia care with TIBA, followed by insertion of nasopharyngeal airway and to let the patient breathe spontaneously in order to assess under the laryngotracheobronchoscopy and to prevent the airway collapse. This was supposed to be followed by topical spray with lignocaine under direct laryngoscopy and followed by laryngotracheobronchoscopic assessment. We had also kept a relaxant on standby if at all the subglottic stenosis needed dilatation, and if the dilatation was supposed to be done, then we had planned to intubate the patient with 3 or 3.5 endotracheal tube for elective ventilation as per protocol for 48 hours. So these are the sequence of events that happened during induction of this patient. First of all, during induction, we found it was difficult to do bag and mask ventilation. However, we continue to provide 100% oxygen through high inspiratory pressures and handed the patient over to the ENT surgeon as the laryngotracheobronchoscopic equipments were all on standby and it was a controlled environment. And the ENT surgeon assessed under the laryngotracheobronchoscopy that the patient had severe re-stenosis. However, he also tried to introduce a 2.5 sized uncuffed endotracheal tube under LTB guidance, but it failed. So we uh, tried to introduce an AMBU aura LMA and continued to provide 100% oxygen, although the ventilation was partial and inadequate, uh, in order to buy us some time. Then after thorough discussion with the surgeon, immediately we proceeded to provide front of neck access for the patient So the surgeon tracheostomized the patient with 3.5 tracheostomy tube. As we all know, once there is difficulty in bag and mask ventilation, everything from there can be downhill. But by discussing proper coordination and taking proper decisions at that moment, uh, we can save the situation. So the key point from this presentation is that once there is subglottic stenosis, you always treat it as subglottic stenosis. Whether it is for the re-stenosis or the whatever the case is, once a subglottic stenosis is always a subglottic stenosis. So what is subglottic stenosis? Subglottic stenosis is narrowing of the airway below the level of vocal cord and above the level of trachea. It can be congenital or it can be acquired. The most common cause for the acquired subglottic stenosis is following chronic intubation, and it happens to be the most common cause in neonates for subglottic stenosis as well. The symptoms of subglottic stenosis are as follows: biphasic stridor, respiratory distress, hoarseness or weakness, weak cry, failure to thrive due to feeding difficulties. Uh, on the right side, you can see the grading system which is provided for subglottic stenosis. There are 4 grades. Grade 1 is when there is no obstruction to 50% obstruction. Grade 2 is when the obstruction is between 50 to 70%, and grade 3 is when the obstruction is between 70 to 99%. Grade 4 is when there is no detectable lumen under assessment, and this can happen sometimes when the web is present in the subglottic region, and most commonly it happens in congenital subglottic stenosis. So a subglottic stenosis can present electively or in emergency scenario. If it presents in elective setup, the symptoms usually are chronic stridor, difficulty in feeding, and history of intubation, or there is already known history of subglottic stenosis. Whereas if the patient is presenting in emergency setup, then there will be a history of acute airway obstruction. There may be severe stridor, retractions, and cyanosis. It requires urgent airway intervention, otherwise it can be detrimental to the patient. So these are the anesthesia concerns in a patient presenting with subglottic stenosis. Preoperatively, thorough airway examination and respiratory evaluation is necessary. It is mandatory to treat the ongoing infections and optimize the general condition of the patient, as an ongoing infection, respiratory tract infection, can cause a patient with elective presentation to present in an emergency setup with acute airway obstruction. And we have to carefully lay out the anesthesia plan, and we have to prepare the airway cart adequately. Intraoperatively, extremely narrow airway limits the endotracheal tube choices. So we have to have smaller endotracheal tubes ready in case if any emergency happens. And risk of total airway obstruction during induction and shared airway with the surgeon may require apnea periods and jet ventilation. Higher chances of airway trauma and bleeding is a major risk. Post-operatively, there is high risk of airway edema and re-stenosis, and there may be possibility of elective post-operative ventilation. So we have to book an ICU bed and ventilator in case this subglottic stenosis cases are being taken. Now we have seen the case scenario, we have seen the examination, and we also know what is subglottic stenosis. So we'll try to apply those things on these airway guidelines or algorithms and try to evaluate how best we can troubleshoot in these kind of situations. So first of all, during induction, we saw that there was difficulty in bag and mask ventilation. We continued to provide 100% oxygen. We checked the equipment, there was no malfunction, and we checked the patient and uh, uh, provided the triple airway maneuver, shoulder roll. We even tried 2% technique, and the situation remained unresolved. So we reassessed the situation, we called for help, and we reassessed whether it was upper airway obstruction and lower airway obstruction. So in our case, it was lower airway obstruction, as we saw that there was severe unanticipated re-stenosis, because as we know, the patient had history of subglottic stenosis. That's why she presented electively. But then we also know from the history and her documents that we could pass 3.5 ET tube post-operatively during previous dilatation easily. But this time we were unable to even pass 2.5 size endotracheal tube. So we know that this is lower airway obstruction. This is not laryngospasm and this is not bronchospasm. We have ruled them out, and under laryngotracheobronchoscopic assessment by the surgeon, it was found to have severe re-stenosis. So under the LTB guidance, the surgeon even attempted to pass 2.5 uncuffed endotracheal tube, and which failed. So we had difficulty in bag and mask ventilation. That is first thing. And second thing is, now this is a situation of failed intubation. So the next best step is to place a supraglottic airway device, and we have to reassess the situation whether the patient is stable or unstable. If the patient is stable, then the next best step is to awaken the patient, and if the patient is unstable or hemodynamically unstable, then we'll go forward with the CICV algorithm, that is cannot intubate, cannot ventilate scenario. In our situation, was the patient stable? Yes, there were very less episodes of desaturation, and the saturation consistently remained above 90%. This is a situation of maybe partial ventilation, good oxygenation, but cannot intubate, cannot ventilate situation, definitely. So the feasible option is to awaken the patient if the patient is stable. But in our case, the question is whether it is feasible to awaken this patient or not. Since it is a case of subglottic stenosis, and the patient has presented with symptoms of re-stenosis again, and now we have assessed under laryngotracheobronchoscopic guidance that it is severe re-stenosis. If we awaken the patient, probably we'll be able to discharge the patient this time, but the patient may end up any time in emergency with similar symptoms, maybe with even bad outcomes. So the waking the patient up is not feasible for us in this situation. So we continue to the next CICV algorithm. So this is an unanticipated CICV situation. We have to continue to provide 100% oxygen, call for help, and patient is stable or unstable. We have to reassess the situation. In our case, as I told, waking up the patient is not feasible. So we proceeded to the front of neck axis by doing surgical tracheostomy with a 3.5 tracheostomy tube. So this is European guidelines flow chart for difficult airway situation, unanticipated difficult airway scenario in case of neonates and infants. There is this three color ranges they have indicated: green range, yellow range, and red range. And this is like an infinity loop. You try to ventilate the patient using bag and mask. You can put airway, you can even provide LMA. If the ventilation is adequate, then you can next go to attempt with an intubation. You can use fiber optic, you can use intubating LMA, or you can do direct laryngoscopy. And then if you fail with an attempt, then you come back to ventilating the patient again. So this is like an infinity loop, but this infinity loop is not exactly infinity, because you have to limit your attempts to 3 plus 1 maximum. So as indicated in this orange box, you have to individualize the your anesthetic plan and airway management to every patient according to the need. So I would like to put our patient's scenario in the yellow range, because uh, although it was difficult to ventilate the patient, we were definitely able to oxygenate. So the patient was definitely not in the green range as well. He was not fully, it was not fully feasible for us to wake up the patient. So I would like to put our patient in the yellow range. So these are some of the examples of severe subglottic stenosis. In this A picture, the subglottic stenosis is grade 3, and in the B picture, the subglottic stenosis is severe, maybe grade 3 to 4. You can see that the lumen is very small, it's like pinpoint. And below picture represents the airway examination by using ultrasound. By assessing the subglottic diameter, we can come to know how bad is the subglottic stenosis. So in case of neonates, less than 4 millimeter is taken as subglottic stenosis. In case of premature infants, premature neonates, the diameter less than 3 is taken as subglottic stenosis. And this is another example of an infant, 4 months old infant with the severe subglottic stenosis, grade 3. This is also an example of acquired subglottic stenosis following chronic intubation. So these are some of the specific neonatal challenges we can face in a case of subglottic stenosis. There may be episodes of rapid desaturation due to high oxygen consumption and reduced FRC. There may be difficult bag and mask ventilation and intubation because of anatomical differences and the nature of the disease itself. And there may be limited IV access. In cases of neonates and infants with limited IV access and with severe subglottic stenosis, the situation can get very challenging when we have to do inhalational induction and simultaneously secure an IV access, and we land up in a situation of difficult mask ventilation or CICV. We have to be very mindful, present, and careful about these kind of situations. There may be immature physiology, unstable temperature, glucose and drug metabolism. There may be increased sensitivity to anesthetic drugs, especially opioids. And team coordination is of utmost importance in case of these kind of complex airway surgeries. So the conclusion of this presentation is that a case of subglottic stenosis is always a subglottic stenosis, whether it is a re-stenosis or not, whether it is dilated or not. It is always a complex airway surgery, and you have to be well prepared in order to manage the difficult airway situation in however way possible. Thank you. These are my references.